Tonight we are looking at assessment. We're going to do this slightly differently. I do have a doll with me in case we need any more explanation, but this is about assessment. And while children get assessed or should get assessed thoroughly every 6 months, some centres do more than others, but in the UK, in theory, every child should be on a programme whereby they are being reviewed every 6 months by a neuromuscular service. But adults, it's all getting a little bit new, and unless you've been on a research trial, you will not be used to being assessed in particular ways, what the assessments are, and actually how you can assess yourself and your own progress, which Treat SMA have been doing by sharing assessments with people. And we will go through the different assessments, how you can look at yourself, how you can look at your children, what information the assessments tell you, and of course, what information it doesn't tell you and the importance of it. So Marnie's going to organise the slides because I am totally incapable, it seems, tonight. So Marnie, let's start at the beginning. And obviously we will stop. That's not the beginning. It's jumped. There we go. Let's go to the next slide. Okay, so why do we assess? We assess obviously for research, and that is very, very specific. The drug companies, the funders, the people who are commissioning the research have a very definite endpoint, be it survival, be it change in scores, be it they want to see whether the drug is working or look at natural history. Well, now we need to establish a baseline when we assess. We need to know where you are at the beginning, because if we don't know where you are to start with, we don't know how much you've changed. So that goes right throughout the age range, right throughout the disability range, from the very weakest to the very strongest. We need to know where you're starting. Generally in SMA, people do deteriorate, particularly in children with growth, but adults continue to deteriorate in the upper limbs, in the arms, generally over time, faster than the normal aging process. We want to monitor change, because if we don't start assessing regularly, we won't know if you've changed. And yes, you can tell us you've changed, but children can't. And parents will see things that we don't see. Unfortunately, what happens with a lot of these assessments is that they are a snapshot in time. They are what happens on that day, in that setting, what happens when you come to wherever it is you're being assessed. It is a snapshot of that day. It doesn't always tell you exactly what's going on. We need assessments to evaluate interventions, obviously. We need to know whether drugs and other therapies are working, be it splints, be it any form of therapy. It could include surgery. You know, if we never evaluated spinal surgery, we'd never know if it worked. So it has to be evaluated. Things need to be tested out. And if they're not right, then stop doing it. We need to know what is good, what is bad. We get unexpected, can be good or bad. Physio interventions, respiratory interventions, big. I mean, a lot of change with respiratory interventions these days. And this is a really important place to assess, because again, respiratory can change quite dramatically. And if we don't know where somebody was, you can't change settings on their machines as well. You can't help to improve things. Now, in the first instance, it can assist with diagnosis. And it's quite difficult now when you are a borderline 2-3. Did you walk? Did you not walk? Did you take 5 steps? Did you not take 5 steps? Can you do it now? And although it's not going to tell you whether you've got SMA, a blood test is going to do that. It will categorize you. Not that that is necessarily useful. You can also look at things called copy numbers, but copy numbers don't always tell you how strong or weak you are. It's very difficult. 2 people can have the same copy number, but they won't look the same. So certainly assessments will tell you what sort of bracket you come into. You know if you're a walker or not a walker. but there are those borderline children. And obviously, you may be a walker, but you may only have ever taken a few steps, which doesn't make you an awful lot different from a child who never walked but was quite strong and crawled and could stand at a bed or something. So numbers aren't always the answer. And certainly I hate this whole idea of treating a number, because you aren't numbers. You've all got different things going on. But what it will tell us is to treat the treatment priorities. So if I have assessed a child and I know they have got good head control, I know they sit well, but they've got weak legs, then I want them in CAFOs. That's not the same with everybody, I agree. But for us, it is a treatment priority. If you don't have good head control, you're certainly not going to stand well. If you can sit, does it mean you can stand in some sort of orthosis or gaiters or standing frame? That we have to assess. And the other thing about assessment is not just a list on a piece of paper that you tick off. Assessment is about looking at every single thing you do. If I was doing exercises with you, be you an adult or a child, and your muscle was not working at all, I am watching that the whole time. I am seeing what my intervention is doing second by second almost. This is not just about every 6 months. As a physiotherapist, your community teams, your private physio, whoever you are seeing, should be constantly evaluating their input. And that's really important. And that is why having physio assistants doing something day in, day out the same way does not always help if you do not see a physiotherapist every so often to actually change and monitor what those interventions are doing. So while there are a lot of very, very good TAs and physio assistants out there, you really do need to see a physio every so often. Next slide, Marnie, please. So what needs assessing? So for research and natural history studies, there are some very formal tests. Functional tests, which some of you would have heard of. Gross motor, can you roll, can you sit, can you stand? And then there's upper limb tests. There are some fine motor tests, not common in SMA, but people are looking more carefully at fine motor, and that's hand function, particularly for adults where it is so essential, because in some adults that may be all you can manage. And the scary bit would be if you lost that, obviously. There are many, many tests of quality of life, well-being, burden of care, and what we call PROMs, patient-recorded outcome measures. And that is a big issue with a lot of drug companies now, that they use PROMs. My personal feeling is I prefer well-being to quality of life, because quality of life only suggests what you are expecting from life compared to what you have got. If you are happy with everything you have got, even if it's very little, then your quality of life is good. If you really are very unhappy with everything you've got, even if you've got everything in the world and you're a type 3 who can walk, then your quality of life is poor. So quality of life is more about hope and expectation than it is about what you've got and what you can do. So my preferred tests are well-being tests. How well you feel, how well can you face the day, how do you feel in the middle of the day, are you flagging, are you tired, are you sore, are you happy generally, are you not happy, do you get depression? These sorts of things, I feel the well-being tests actually evaluate better. There are a lot of time tests, and the reason there's a lot of time tests is that they are very, very easy to reproduce. When we talk about time tests, you know, you start the stopwatch, you finish the stopwatch, and you have an objective number. It's not subjective, and it's not a number assigned to a task. It is actually an objective number. So time tests are very popular because they're more accurate than many other measures. Respiratory measures are obviously important, and that's something that needs to be done on a regular basis. I personally don't do them. We have a respiratory physio and we have a physiology department. But the sort of thing that they're looking for are how big a breath you can take, how hard you can blow out, the number of hours of ventilation. They're looking for hospital admissions. And obviously survival is a major factor and one of the biggest and most common, would you believe, outcome measures in any disorder. Next slide, Marnie, please. We can measure fatigue. This is my favorite fatigue scale, the one at the top. I think it's one of the nicest pictorial scales, which shows how much could you go on from here. And obviously 10 is you are so fatigued you have to stop. And 1 is no, I'm fine, I can keep going almost indefinitely. The big problem is obviously there are scales in between and it's much harder for children to judge exactly how fatigued they are than adults. There are many, many pain scales. The one at the bottom there has 6 faces. Many of them only have 5 faces. The pain scale goes up to 10. Many children overestimate their pain. The pain at 10 is thought to happen so infrequently that very few people would ever get to a 10. And then a lot of adults underestimate their pain and don't complain about constant pain because it's there all the time. They're so used to it, they don't even think of it as pain anymore. So it's actually pain, again, is a very subjective measure. It can't be tested. Some people say they have pain all the time. You can't say you don't. It is purely subjective. But obviously pain can be how long, what makes it worse, what makes it better. Those sorts of measures are more important. Now, importantly, when measuring pain, it's actually really difficult to use pain scales because not only are we talking about pain, whether it's intense, is it discomfort, but there are many types of pain. There's burning pains, shooting pains, aches, cramps. There are many, many different types of pain. And obviously the type of pain suggests the origin of the pain. There is mechanical pain. There are nerve pains, neurogenic pains. So there are different types of pain as well. And different types of pain need different treatments. Now, apart from fatigue, we can try and measure endurance, which is the time an activity or function can be continued, which is similar to fatigue, but endurance can include pain because why are you stopping? Why are you not going on? What is it that's preventing you from continuing? And it's very difficult to measure. And even when we're looking at pain, fatigue, and endurance, we need to put that together with function and how they interfere with function. So it's not always that easy to evaluate on a numerical scale and therefore not often used in research to calculate results. Next slide, Marnie, please. There are many ways of looking at fatigue. There are up and down steps. There is the one with a little shadowy figure saying 20 meters is what we call a shuttle test. And that's basically just running backwards and forwards until you basically are a little sweaty blob on the floor. And at that point they stop. The box with the colored bricks in one side is an arm test. There's actually a little wall in between the two sides of the box and you have to take the bricks and put them from one side to another. And you can either do the number of bricks in a set time or you can literally do it until your arm stops dropping. And the boxes at the top are also measures of fatigue that you wear. Next one. Looks like this has got a little bit out of order because this is all about pain. But as you can see, there are many different causes of pain which make it pretty hard to evaluate. Let's skip that one and go to age. Okay, let's just check because there's a little bit missing at the bottom on that one. Obviously, age is an issue. If you are very little, there are things we wouldn't expect you to do. If you're only 7 months old, you probably wouldn't be walking, running, hopping, or jumping anyway. So you have to be a little bit sensible when you're looking at assessments as to what a child can actually do. So you cannot ignore age. Normally, age scales will go up to about the age of 5 to 7. So what you're looking for is a child of 5 should be able to hop. And on that basis, any scale that includes hopping needs to be tailored to a child who's under 5. And there's other things. I mean, when can you do a sit-up? Actually, there's no record of when the child should be able to do a sit-up. Admittedly, not many children with SMA can do a sit-up, but there is no age to it. But obviously, understanding and being able to say to a child, you know, again, at 8, 9 months, you can't just say, okay, roll over and crawl up and do this and do that. You have to encourage them through play and look at what you can. One of the big problems with assessments is we have to fit the child and even the adult to the assessment rather than the other way around. We don't fit the assessment to the individual. You have to fit that assessment. So there are many, many things that parents will say or adults will tell us that just aren't on the scales. And we know that. We know that certainly when we started the salbutamol, and that's many, many years ago, that's in the 90s, we started using salbutamol at Hammersmith Hospital. And one of the girls said that what she noticed when she started salbutamol was she could pick up her own guitar. Well, strangely enough, that wasn't on any assessment sheet. We had 3 of the boys whose main interest was the fact they could now open a crisp packet. And one of the boys who had 2 younger brothers was very proud of the fact that he could fight back. Most importantly, we had a young lady whose biggest achievement was she was able to get up from the floor by herself. She was a type 3, and it was something she hadn't been able to do for a long time. And somebody said to me, what's the big deal if you need to use furniture? I said, well, it makes the difference as to whether you'll go out in the garden or out in the street. If you fell over and you needed furniture to get up, you're not going to go into the garden, climb up on a rose bush or into the street and try and climb up a lamppost. So it can make a big, big difference, little things. And yet on an assessment, being able to get up from the floor may only score you 2 points, but it's enormous if it makes a big change in your function. So we'll come back to this idea of numbers soon. Okay, we need to be sensible. Next slide, Marnie, please. We need to think about well-being. And one of the things that we get a lot is that if you have traveled a long way to a centre and you're then suddenly expected to get out of a car, having traveled or even off a train and having traveled for 2 hours, having got up at 5 o'clock in the morning or sometimes earlier and being expected to do a whole battery of tests and have bloods done and maybe x-rays and this and 6 other people want to get hold of you. You know, it's a lot. It is a lot. There are centres that will do it overnight, but that means maybe taking 2 days off work for adults. For parents, it may mean missing 2 days at school. It's difficult, and it's also quite stressful to be on a research trial, particularly a drug trial. Now, many of the drug trials now do not use a placebo group. People will get treatment, but at different levels. Obviously, they have done safety trials first, and they know the dosing they're looking for, but they will give different doses. They know safe doses, but they want to know which. And it's not always that by giving the biggest dose, you will get the biggest effect, because sometimes the curve can flatten out so that you could keep going up and up with a dose of a drug and not get any more effect than a lower dose. So obviously you don't want to overdose. The other thing we don't like particularly, well, when I say we, my team don't like, is putting a 6-minute walk test for type 3s at the end of an assessment. So you've done a whole day, you're absolutely fatigued and flagging, and then they take you off to do a 6-minute walk test and expect you to perform, which is madness, based around the idea that we know SMA is a fatiguing condition and that you will get tired. There is absolutely no value in doing the 6-minute walk test last. And when we assess clinically, we always do the 6-minute walk test first. And the other thing that we try and avoid is around blood tests. Because one thing that if you have been a pincushion for an hour and a half and people have tried every which way to get blood out of you, the last thing you want is a physiotherapist coming and telling you you've got to do this, 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 and this. So it's more difficult now with the nusinersen. We are finding we're having to do assessments around nusinersen injections, try and stop bringing people into the hospital too many times, particularly with COVID. But it does mean that some of the children are really not up to doing an awful lot when they've been used as a pincushion. Next slide, Marnie, please. Now, one of the problems that we have with new treatments is what we knew as natural history. In other words, what we would expect a good type 1, a weak type 2, a stronger type 2, and all the different type 3s to do because we knew, because we'd collected all that data and we had a lot of information, has completely gone out the window. We can give 2 almost identical type 2s the same treatment and they'll look very different at the end of it. So we have nothing. When parents particularly or adults say, what will I get from this drug? We don't know. We seriously do not know because you will not get the same as somebody else. So you can have 4 young ladies going through risdiplam or nusinersen treatment or whatever all together, and they will all have different effects depending on where they started from. That's the first thing. How contracted, where the results are, how strong were you to start with? So many, many things will affect your outcome. Next slide. Okay, now we do not choose the scales used in research, but we can choose what we're doing with the children in clinic, and we can make recommendations to suggest things that will help. So when we're looking at scales, we want them to be fairly quick. And one of the problems that we have with one of the scales is that they can be quite enormous and they have an enormous number of items. Now, admittedly, if you're not a type 3, you won't be doing all the standing and walking ones. But if you are a type 3, you still have to start at the beginning and go all the way through to the end. So you still have to do the rolling and all the things you did before and then do all the standing ones. So it is a bit tough on the more functional people. It should use minimal equipment because the more equipment you need, then the more you have to standardize and make kits so that everybody is using the same thing. So this is a big problem that we have with the upper limb scale, is not only do you need to get the kit, but the kit can wear out or you can lose bits. We have some coins to pick up coins and ours have gone rusty, which is not terribly endearing when you have to pick up these nasty looking rusty coins. We should order some more. Ideally, the scale should be ordered by difficulty. So then you know that if you can't do this item, don't keep pushing and pushing for another 20 items. But if they're jumbled up and here and there, then you don't always know which ones you're trying. And if they start off in standing and then they go to sitting and then they go to lying and then they go back to standing and then back to sitting, it can add fatigue. But if they're ordered by difficulty, it also helps in terms of treatment, because if you know that the next thing from rolling is being able to get from sitting to lying, and I specifically say sitting to lying, difficult when you're a big adult, but not so difficult when you're a child, then that's the thing the physiotherapist should be working on. They can't at the moment get from sitting to lying, but you know, otherwise the only way they can lie down is by falling over or somebody putting them down. Then we teach them all anyway, but it's the next thing. We don't want tons and tons of paperwork, even though the MAA, which in the UK is now the Managed Access Agreement, and we have to. NICE want us to, I think there's about 15 pages worth of assessments that have to be done. And this is really difficult because you just end up with a ton of paperwork. We want something that can be used on the very young. We want something that's fairly self-explanatory. We don't want 100 pages of manual and pictures and things that we have to keep reading through. We want something that's very easy for us to learn as well as to perform. We need all these scales to reflect the abilities of SMA. Now, most of the scales we're using at the moment were developed for SMA. Some have been doctored for SMA, but there are still things in the scales that you wonder if people have ever seen somebody with SMA when they're trying to do some of these things. And one of my favorite is squat, because I think there's 1,000,001 of us out there who can't squat and we haven't got SMA. And I'm not actually that convinced that even when at my age and my stage in life, that I use squatting very much. And in fact, the last time I remember squatting was when I was camping in the desert. So that is 10 years ago. And we don't use it very often. And when you are squatting because you're camping in the desert, it's a totally different ballgame than if you're trying to squat just to show somebody how far you can stick your bum out. But we need to be a little bit realistic. Okay, so let's have a look at the next slide and we will see what they should be. So functional scales, that's the ones that are looking at rolling, lying, sitting, arm function, fine motor function. They should be valid and validated. In other words, they should be tried and tested and relevant to the population group, to the diagnosis, to the age, and to the change. And some of the assessments are far too difficult for the weaker people, but then they're far too easy. Some of them are far too easy or not relevant to age. And that's really important, because one of the issues that we're finding is that something like the CHOP, and we'll talk about that, is being used on much older people than it was ever developed for. They should be reliable. They should be sensitive, in other words, easy to see change. They should be feasible. In other words, they're going to produce a result that's going to be useful. They should be timely. They shouldn't take ages to do. They should be easy to teach and apply. In other words, to train shouldn't take forever. You shouldn't need 4 certificates and 15 reviews, and they shouldn't keep changing the scales, because one of the annoying things about changing scales is actually the more times you change a scale, the more you're going to lose data, because in theory, all your data up until that point then becomes obsolete if you keep changing scales. And obviously, as I say, this should be clinically meaningful. This should be useful for clinicians as well as researchers. Next slide, Marnie. Any questions coming in?
Yes, we have got a few.
Okay, let's stop for questions because I quite like this picture.
Are there any real-world evidence trials with capture of how treatments enhance day-to-day life?
Well, in theory, functional scales should do that. I mean, if you are looking at somebody who is ambulant, who couldn't climb the stairs or climb a step, then the functional scale should show whether they can then climb a step or lose that ability if they had it before. Can you get up from the floor? Can you roll over? Can you sit yourself up? So most of the scales, the original Hammersmith scale, which we developed 20 years ago now, was based around the functions that type 2 SMA children could do. And we did 180 assessments looking at children, and these were all things that they could do. Can you crawl? Have you lost the ability to crawl? Have you gained it or regained it? And all these scales should be showing you something useful. Now, there is real world. You may think that respiratory is not real world, but if you improve your what we call respiratory reserve, in other words, you're getting more air in your lungs, you can cough it out harder and faster. They are all meaningful results, even if they're not relevant to you. You may be a type 3 who's never had a chest infection. But on the other hand, we are seeing that some of the type 3s who lose ambulation early are just as prone to chest problems as some of the type 2s. Is crawling relevant? Well, if you're an adult of 54 and really you have absolutely no value in whether you can crawl or not, you're not going to be terribly interested if you've gained or lost the ability to crawl. But to a child or to a person who finds that actually it's an effective way for whatever reason to get from A to B, then yes, it's important. Can you lift your head? Is that one of the most important things that you need to be able to do? Lift your head. Do we lift our head that much? I mean, how many of us are lying down and lifting our heads up? It's one of the classic things that we look at in functional scales, and yet you don't need it to roll over. You don't need it to sit up when you can roll onto your side and push yourself up without lifting your head straight away. Can you do a sit-up? Does it matter? As long as you can use your arms to get yourself into sitting. So most functional scales will look at meaningful outcomes because that's what they're designed for. The problem is we can't look at every outcome that is meaningful to every person in the population. But that doesn't stop you as an adult recording changes that you have seen. And we'll talk about that when we come to the EK scale.
Okay, we've got one saying, I always find it frustrating because some appointments are first thing in the morning and 6 months later are in the afternoon. Do scales take that into account?
In theory, you should always be assessed at the same time of day. And in a research trial, they stipulate that. So that if you're having research, you should always be assessed at the same time of day. There are, on most scales, of things saying time. But then you have to look at other things apart from the time of day. Have you just eaten? Did you have a chest infection last week? Did you have a chest infection yesterday? Have you recently broken your arm or fallen out of your wheelchair or had a kidney infection? So there are more things than just the time of day that we need to take into account when we're looking at scales. And one of the things that a lot of parents have got worried about is this idea that NICE are going to withdraw treatments. And, you know, if you've lost 2 points on a scale, are NICE suddenly going to stop you having nusinersen? And if risdiplam comes in, will the same thing be said of risdiplam? No, is the answer to that. Everybody expects to have a little bit of background noise, as we, you know, to use a term fitted into medicine. You are not going to go along a straight line the whole time. So we will record that you were ill, that you threw up in the car on the way, that you had a chest infection last week, that you've just recently come out of plaster or had an operation. Of course, these are all very relevant to the score you achieve on the day. And that's what I meant when I started by saying this is a snapshot in time. This is today. Tomorrow, you may be able to do one of those things that we said not. Yesterday, you may have been doing everything and you're not in the mood today. And that's particularly true of kids.
Okay. Do you find that as contractures get worse, progressing in scales becomes harder? So if you can't do something on the scale, it's not always necessarily down to strength.
Absolutely. And in fact, we did this with the original Hammersmith scale 20 years ago. And what we had was a little column that said limited by contractures. And basically what it meant was that it was the contracture getting in the way, not necessarily the power. What we're doing now is a bit A over T, because what we're looking at is mild, moderate, and severe. And mild means they don't interfere with function. Moderate means some interference with function, and severe means lots of interference. But that's equally unmeaningful because we've got kids with no contractures who can still do nothing. So the fact that you only have mild or no contractures does not do the opposite way around. It doesn't give you the power to do the movement. So it can work both ways. You can have lots of contractures which will interfere and no contractures that don't interfere, but you still don't have the power to do the movement. Does that make sense?
Yeah.
Makes sense to me. I hope it makes sense to you. Okay, more questions?
Yeah. Are the drug companies going to invest in training up more physios on this type of thing?
I have to be honest and say they are all pretty good. Biogen have put a lot of money in the UK into training. When they do research trials, and that's all the drug companies, if physiotherapists or outcome measures that physios measure are part of the study, then yes, they train the physiotherapists. There's a lot of training goes on. That doesn't mean to say you will find a physiotherapist who knows SMA and will treat you accordingly. Research trials are totally different things from clinical treatment. And if you can't get a physio for love or money, being on a research trial will still not give you a physio in the community who will treat you. And the research physio who does your assessments when you come to clinic will not necessarily spend hours and hours looking at your contractures and your exercises and your ball work as we were doing last time. So there are plenty of physios trained to do the research trials, but that doesn't necessarily mean they will treat you.
Okay. Is there a scale that monitors swallow or lung capacity?
There are many scales that monitor lung capacity, and you should be having a regular sleep study, which looks at your oxygen exchange, particularly in bed at night. Many of the tests you are doing look at your oxygenation. Even just having one of those things on your finger will tell you what your oxygen saturation is. You will do respiratory tests, blowing out the candles, and you should, in every clinic visit, be you adult or child, which is why adults need to be under a neuromuscular service, and I'm finding more and more aren't, that they will monitor with different tests your lung volume. Swallow, yes, but only if you are having difficulty. There is a little bit about swallow on the EK scale. Again, this is something we will talk about, but actually swallowing, the most effective way of looking at a swallow is by doing what they call a video fluoroscopy, which is where they give you a radio opaque dye to drink, and you drink it, and as you are drinking it, they are taking an x-ray, well, it's like an x-ray of your swallow and watching where this stuff goes, whether it pools in the back of your throat and sits there, or whether you're actually getting a tiny bit sliding into your lungs, and that can be what they call silent aspiration. You don't realize you're actually doing it because it is a minute amount with each swallow, and your swallowing system, and I'm not brilliant at on all the little bits in there, you can have, if it's quite floppy, you can have this silent aspiration without knowing it. And that's one of the most difficult things to know about. But yes, there is video fluoroscopy that is usually done with a speech and language therapist because they work on a swallow. People think it might be a dietitian. It's not, it's speech and language therapist. And if they are concerned and you're concerned, they will arrange a video fluoroscopy.
Okay, I think that's it for questions for now.
Okay, let's go on and have a look at all the different scales. This is all a bit over the top, I accept. Next slide. Okay, so the HINE is the Hammersmith Infant Neurological Examination. It was developed for premature babies. I will show you a picture of it. It's quite basic and it can only be used up to a certain age. The North Star for SMA3, which is a nice scale, has largely been abandoned because it wasn't taken up for a lot of the trials. So it's very, very rare. Some bits of it have been integrated into the Hammersmith scales that are now predominant. But the North Star is pretty much redundant, which is a shame because it was quite a nice and quick scale. The Hammersmith scale, we have two. We have a revised Hammersmith and a Hammersmith expanded, goodness knows what. I mean, there are so many versions of the Hammersmith out there that it's all got a little bit silly. But we have now gone on from being the original 20 items for type 2 to being about 37 or 38 items. I think one of them's out of 69 and one of them's out of something similar. And they're unrecognizable, but there's everything from sitting, because it is a scale from type 2 onwards, or certainly from sitting onwards, so sitting type 1s, up to walking and stairs. Now, Brook and Vinyos are interesting because they're not really scales as such, they're more descriptive indicators. Brook is an upper limb scale, and it just tells you whether you can bring your arms over your head straight, whether you have to do it with your elbows bent, whether you can get your hands to your mouth, whether you can lift your arms. So that's the Brook scale, which is just really a very basic, where is your upper limb function? And the Vinyos scale that we use is the Vinyos scale of motor function, which goes from fully ambulant and can do stairs to totally wheelchair dependent. And that is a scale from 1 to 10. It doesn't explain everything because it talks about can walk in calipers, but then there isn't one where you walk in calipers, but also use a wheelchair. So it's a little bit iffy, but it gives you a very basic idea. The EK to me is one of the best scales. Thankfully, it has come back into fashion. It disappeared for a long time, but it's a really nice scale of activities of daily living and general activity that people, particularly adults, although they are using it from 7-year-olds, it was never meant to be for us 7-year-olds. It was an adult scale originally, or certainly teenage scale. It was originally developed for boys with Duchenne muscular dystrophy when they lost ambulation, but it was expanded to SMA. And it's a lovely scale. We'll talk about it in a minute. And it's thankfully very much more in use. And I know Treat SMA have been working with the adult population on trying to get people to fill it in, and not only fill it in for where you are now, but how you've changed over the last 10 years. And also then be able to monitor your own changes between now and going on treatment, or even monitor yourself on treatments. The MFM is just a French scale. It's used in some of the French studies. So Roche often use the MFM in their work, and it is a scale that the only problem with the MFM is it wasn't developed for SMA. It was developed for all neuromuscular disorders of all ages, and so is not all relevant to SMA, but is pretty similar to the revised Hammersmith. The CHOP Intend is for the weakest of type 1. It was only supposed to be being used up to the age of 2 and has now gone on a lot older than that. But they are now developing something called the ATTEND, which is the adult test of neuromuscular disorder or neuromuscular disability. It's all done from a wheelchair. It does require that your wheelchair reclines. My honest feeling is that it will tell you if your legs are working, but very often contractures and weakness are going to get in the way anyway. So as a functional scale, I'm not convinced. There's upper limb scales, the revised upper limb module, which I think is an essential scale, although very few people can actually safely lift a 1 kilo weight. There is the PEDICAT, which is an American version of the PEDI, which is the Pediatric Evaluation of Disability Index. It's looking at all sorts of daily function, from can you push your wheelchair, can you clean your own teeth, can you dress yourself, can you feed yourself, all sorts of things, even to getting on a backpack. And then the Bailey and the Peabody are very much infant developmental scales that may or may not be used in some centres. And they're looking at gross motor, fine motor, socialization. They are very, very extensive assessments and really take quite a long time. So the only beauty of the Bailey is there is upper limb stuff in there that is not tested on in any other scale for little children. Next slide, Marnie, please. Okay, time tests. And as I say, the beauty of time tests is they are objective. They give you a number, 6-minute walk test. Now, 6-minute walk test is quite a scary idea for a small child to think that they have to walk 6 minutes. So we don't call it 6-minute walk test with the younger children. We call it the how far can you walk test, because in theory, you only have to walk 2 minutes and that's still a test. That is how far you can walk in 6 minutes, 2 minutes worth. If you do 200 meters and that's it, you stop, that is your test, whether you've done 6 minutes or not. So actually, as long as you do at least 25 meters, you have done the test. 10 meter is, it's very, very common, but it's difficult to measure for the very ambulant because actually you're still accelerating by the time you get to the end of the 10 meters. Time to rise from the floor is exceptionally not well received with adults. They do not like getting on the floor in the first place. And actually quite a lot of the teenage type 3s are a little bit worried about getting on the floor in case they have difficulty getting off. Timed stairs, timed up and go is when you stand up, you walk 10 meters, I think it is, or less. It might only be 5 meters. You turn around, you come back and you sit down again. And then, as I say, there's the shuttle tests. But time tests give you a number that is numerical because any functional scale represents a function with a number and therefore can never be accurate, irrespective of how many statistical tests you do on it. You cannot say that lifting your head, which scores 2, is the same as squatting, which scores 2, which is the same as climbing stairs, which scores 2. So that it's the same 2 or 3 or whatever for all these different functions. And so irrespective, as I say, of what statistical analysis says, time tests definitely give you the most accurate results, although I do like the upper limb for that as well. Next slide. This is sort of assessment of the future. The funny rocket looking thing, the grey one, the step watch was looking at steps, but there are many, many things, even a Fitbit, Apple iWatches, all sorts of things that are being tested and tried now to save all these assessments, to look at what you're doing. Some of them will measure your heart rate, some of them will measure your respiratory rate, your blood pressure, the color of the clothes you're wearing, you name it, they'll measure it. And this is possibly where things are going to be going for drug trials of the future, because you just have to wear it. Now, the problem is you just have to wear it. When do you take it off? Do you wear it in bed? Is it comfortable? Can you go swimming in it? So can you wear it at school? One of the problems we have is that some of the kids aren't allowed to wear them at school, so that becomes an issue. But generally, I do think this is where we're going to be going because they are much more accurate than a lot of the assessments. Marnie, next slide, please. Okay, now one of the big problems we have is assessing the very weak. If they are really exceptionally weak and are not doing very much, all we have really is the CHOP. But if I can show you the Heine, next slide, Marnie, please. This is the Heine is looking, this is not developed for SMA. This was developed for premature babies and to look at whether they had caught up with their normal development. So we're looking at normal head control, normal sitting up to the point where a child can pivot, voluntary grasp, and you'll see under the pivoting, it says 9 months. So 15 months in theory is the highest this goes up to because it's walking independently. So 9 months for pivoting, voluntary grasp, which is also on the CHOP, ability to kick. And some of our type 1s can do this brilliantly, and some of them can't even get their legs off the bed. Rolling, crawling, which many of them don't achieve. Some of them do now, but some of them miss that out completely. Standing and walking. So that's the Heine. It is being collected for the little children on the MAA, but the value of it is difficult because actually it's quite a crude test. It talks about sitting with supported hips. Well, how much supported hips? It's all these questions are not really answered. So it's a crude scale, but it is being used. Next slide, Marnie. Okay, as I say, it compares to expected normal, which SMA isn't. It's a good measure for long-term analysis, but you can't do it for 3 monthly, you would have to look over 6. But as I say, it's not well defined and it doesn't look at quality of movement or compensation. Next slide, Marnie, please. The CHOP Intend, which a lot of you will know about, was developed. It was published in 2010, so it's already well over 10 years old. It was developed from another infant assessment, the Alberta Infant Motor Scale, but it was developed initially specifically for type 1 and only for the under 2s. And of course, the reason that it was only for the under 2s was because in those days, 12 years ago, very few type 1s did survive past the age of 2. Now they virtually all do, which is fantastic. Next slide. Okay, this is the exciting equipment that you are allowed to use to do the CHOP. It is just overwhelming. We are allowed bubbles now. The rattle is, I mean, just as basic as you can get and as boring. And that awful teething giraffe. And I haven't put the picture up, but one of my favorite pictures is if you go onto the internet and look at pictures of this thing cut open, you will find it is riddled with mold and gunk and all sorts of disgusting things inside. And they're pretty vile and I hate them. And when you've got a 7-month-old who only wants to look at a phone or an iPad, you're not really going to entice them with these two things. So we have to think about the equipment that we decide is relevant. And this is what we've got for the CHOP. Personally, we don't, because we're clinicians and we don't have to use these awful bits of equipment. Next slide. The CHOP is a strange scale. There are 16 items. We don't need to go through all of them, but if you look through them, you will see that number 5, number 1 has 0, 1, 2, 3, 4, as do the next ones, until you get to number 5, which has 0, 2, 4. So it misses out the bits in the middle. And then if we go to the next slide, Marnie. Is that the next one? Yes, the next page, you will see that most of the last of the items misses something out. And if you look at number 10, there's no number 3. So it's all very strange. It's not quite even. They're not all measuring the same thing. And then the last 2 have the baby hanging upside down in this sort of wonderful position, ta-da, which is horrible. So it's pretty hard to do a 5-year-old in that position. But they have wiggled it and developed it and changed it. And yes, it still works for the weak, small babies, but certainly it doesn't work for the over 2s very well. But then we do have other things coming through. Marnie, let's have a look at the CHOP. It's not my favorite. It was developed for SMA, which is wonderful. It uses minimal equipment and it can be done over several sessions. But as you can see, that's those 2 pictures show the baby in suspension, which is not their favorite position. And also when you pull them to sitting and their head gets lost backwards, it's really quite difficult for them to do anything. The negative side is that it doesn't overlap with the SMA2 scales because sitting ability is not tested. Some is distressing, some is not suitable for bigger children. The scoring's not uniform. It can be extremely fatiguing for some of the fragile babies. It's very hard if you've got a tracheostomy to complete some of it. The tracheostomy gets completely in the way and it doesn't always measure the. When you are doing a trial, you only ever give one side, the better side. So what we found is when we were doing the CHOP initially with some of the babies, that they may look as though they're not improving. But what was happening was the difference between the good side and the weaker side could be 5 or 6 points. And what was happening was the good side was not improving, but the weaker side was. So you were missing that improvement by only collecting one side. So I'm not sure now whether we're collecting one or both, because as I say, I don't do research, but that was a disadvantage with only collecting one side. So next one, Marnie, please. because this is taking quite a long time. Okay, the Hammersmith Functional Motor Scale Expanded was developed from the original SMA scale to include children with type 3. Additional items are getting up through half kneeling, which is mad because it's not something that a lot of people do. Squatting and stairs, and obviously stairs are really important. But as I say, getting up through half kneeling is not the natural history of SMA, so you are making it very difficult for a lot of children. And it doesn't look at walking or running. So while it does do stairs and it does do squatting, it doesn't talk about walking at all, which seems a little bit silly. Although I do think they do a time test on there. The next one are the arm scales. There's 2 scales, the PUL being the newer version. It's a mixture. It's a mixture of scales, which is irrelevant in a way. What it doesn't do is it doesn't take into account the fact that many adults and children with SMA have very lax, bendy, over-mobile fingers, which can make things like tearing the paper difficult, getting the Ziploc difficult. And it may not be lack of power, but just maybe those bendy fingers that seem to go in foreign directions when they're challenged at some activities. Next one, this is pictures of the PUL. This is the mat that comes with it. Next one, these are the weights, cans, coins, which go nice and rusty. Pencils, which you've got to remember to sharpen, because that's what happens. There's a little light that you click on and off. And those weights go all the way up to 1 kilo. Next picture, next slide. Okay, this is my favorite, certainly one of my favorite scales. It was for a good 10 years totally lost. People weren't using it, which was a shame. Excuse me. EK, it's a Danish scale. EK stands for Our House because it was developed by them with adults with Duchenne muscular dystrophy, and as I say, then with SMA. Originally, there were 10 items, and then a lot more added, and you'll see that they're very relevant to SMA. One of the problems is the scale's upside down. If you score 0, you are very functional. And if you score top marks, and I'm not sure what top marks are, I think it's 51, then you are very unfunctional. And the reason that it was done upside down was because what they said was that it was very depressing for very weak people to always score 0. So they did it upside down, which is a little bit confusing. But it does mean if you score sort of between 1 and 5, you're really very functional. So you will see, let's have a look at the EK scale. I hope you can see this. So, excuse me. The first one is ability to use a wheelchair, and it looks at being able to push a wheelchair. And it's interesting because actually we have pushed a few kids and said, can you push your wheelchair 10 meters? No. But actually, when you make them do it, they can. It's just they never do it because mommy and daddy push it, or they're always using an electric one and they only have the manual in clinic with them. So actually, it's a very good exercise. More people can probably do it than realize. So it might be something worth practicing. And this is the beauty of this scale. You can actually use it as a sort of treatment thing to think about what you can do and what you should be trying to do. So ability to transfer from the wheelchair, which obviously for most people is pretty difficult. Ability to stand, ability to balance in the wheelchair. Can you move forwards and come back up again? Ability to move your arms, ability to use your hands and arms for eating, which is obviously important. Let me just see, because it is a bit small, this thing. Can we make it bigger? Okay, then the next one is the ability to turn in bed, which is important for a lot of people. The ability, where have we got to? The ability to cough, which is obviously important. The ability to speak and how loud. And it's interesting that we've noticed quite a lot with nusinersen that a lot of the children have got a lot better and a lot louder. And that's particularly useful in school. Physical well-being is in there. How do you feel good, easily fatigued, loss of weight, loss of appetite. So there are things about that. Daytime fatigue is looked at, head control is looked at, ability to control the joystick, food textures. Can you manage chewy foods or just soft foods? How long does it take you to eat a meal? It looks at swallowing and it looks at hand function. Can you unscrew the lid of a fizzy drink bottle? And the answer is always, well, it depends if it's been unscrewed before. Is it first time or not? Can you write 2 lines using a computer or keyboard? Can you write your signature or use, or can you not use your hands at all? Now, there's a lot of functions are not in there. But again, if you can get hold of this scale, and it's easy to find on the internet, you can download it. You can assess yourself on this scale. This is the beauty of it. You can, as an adult, actually assess yourself and make comments, and then look again in 3 or 4 months and see if you're changing, and look at yourself and how things are changing over time. And as I say, you can also use it as a treatment thing. Is this something that you should be trying to do? Push your own wheelchair. And generally, as I say, the higher the score, the weaker you are. So you know you are trying to achieve the higher level on the scale. Okay, next slide. The time tests. I don't think we need to look a lot at the 10 meter. It's a fairly easy one to look at. Next slide. 6-minute walk test. It is validated in children. We've used it with 3-year-olds. The biggest problem with the 6-minute walk test is the space. You ideally need a 25-meter track. 20 meters is fine, but the shorter the track, the more times you have to turn. So you have to think not only about 20 or 25 meters plus turning space, but obviously each time you turn round at the end, you lose time in the turning, so that it needs to be standardized. So if you're doing a trial, the likelihood is you will be asked to do a 25-meter track. And you do need to be able to achieve a minimum distance. It's usually 1 round of the track, so it's 25 or 50, depending on the trial. And the question is always, is it related to quality of life? Does it matter how far you can walk? For some people, it does. What we always said was it doesn't matter to the Americans, because basically if they have to walk for 6 minutes, they jump in a car. Very few of them will ever walk to school. So it's maybe more relevant in Europe than it is in America. Do you want to be able to walk 6 minutes? Do you want to be able to keep up with your peers, or is it easier to jump in a wheelchair? And that's a fact of life. It's not a criticism. It is a fact of life. If it is easier to jump into a wheelchair or a buggy or on a scooter, well, that's fine, if that makes life better. Next slide, Marnie, please. This is just our 6-minute walk test track. It is 25 meters. It goes the length of the corridor. We were offered a whole street with trees and cars and all sorts of things, but we said no, because we thought the drug companies would say it's too distracting, which it would have been. But it is a fantastic track. It's very easy to use, and it does make it much easier for the children to see how far they've been and where they have to go. Okay, next slide, Marnie. The interesting thing is this is the sort of thing you get from the results. We like this. I mean, it really does show how things change. Now, the top one was a young man of 11 who did 330 meters, but then had a massive growth spurt and lost ambulation at 13. So the fact that he could do 330 meters at 11 didn't actually tell the whole story, because he did deteriorate quite rapidly. But what you can see is from the first lap, which was slower, and then he speeded up, and then he sort of had a second wind after about the 8th lap. But if you look from the first lap, which was about 23 seconds, to the last lap, which was 40, you can see the fatigue. And then with the other young lady who was 8.5 and actually lost ambulation just a couple of months after this, you can see she only managed 4 laps. That was her total. She only did 105 meters, and you can see how she struggled over those 4 laps. And it was over 100 seconds, which is 1.5 minutes to do the last lap. So it was very, very hard, from 40 seconds to 1.5 minutes. So we do like the 6-minute walk test for the ambulant children. We think it tells us a lot. Next slide, Marnie, please. Okay, we need to think about the child's well-being, but also the adults. It's a long day, there's a lot going on. You need to make sure you are well and feeling up to being tested and having all the interventions. Next slide. One of the problems we have with some of the babies or some of the infants is that communication can be very difficult for some of them. And if they can't communicate effectively, they don't feel that they're being well discussed, that they're not interacting, then it's much harder to get some of these tests done well. And we found that the more we can interact, and even if you do it, I mean, I had one young lady of 5 years old, we managed to establish a sort of squeeze my finger once for yes and squeeze it twice for no. And once we'd established that, she became much more interactive because we could understand each other, and I could certainly understand her better, and she liked that more. Next one. Okay, outcome measures are not the same as clinical outcomes. Clinical outcomes do not mean that you have scored 2 points or not scored 2 points. What we're looking for clinically are very, very different things. One of the things that you will never see on a trial is measuring a scoliosis, accurate measurement of hip joints, looking at whether your splints fit. So these are the sorts of things that clinical outcomes are all about. And treatment and clinical outcomes are as important as measuring outcome measures and everything else. And one of the big problems we have with research and with all these assessments is that what we're finding is that the clinical is being thrown to the side a little bit, and children are missing, and adults probably even more so, are missing a good clinical hands-on assessment. What are you up to at the moment? What exercise do you need? Where are your contractures getting worse? What are they interfering with? How is your spine looking? All these things need to be done as well. Next slide, Marnie. So I think the bottom of that slide is probably the most important bit, and that is that the changing cohorts are presenting management challenges not previously experienced. So we're seeing a lot of type 1 children, we're seeing a lot of type 1 children who are sitting, we're seeing a lot of type 1 children who are standing in CAFOs, we've got type 1 children who are walking in CAFOs, and I know that's something that we do at GOS because we insist, and I know there's some other units that do it as well, and I know there's many units who do not believe in CAFOs, we do. And that's again a clinical difference, but a lot of the problems we're seeing in type 1 we've just never ever met before, and these are clinical problems that we need to consider, as well as the assessments for trials and drugs and everything else. Next slide. So we need to think about this from a clinical thing, and this is all part of assessment, that the increasing population of infants and children with severe complex needs, and these people are going to be adults soon as well, and this is really important for adult physios, and I don't think they know what's coming to them, is that it's not only medical and therapy, but housing. And we know this from Treat SMA, where we have here mum who's got major housing issues, and she's certainly not the only one. Transport, communication is a big problem for some of the children, socialization and schooling, and ignoring COVID. We're looking long-term independence, because irrespective of how weak or how strong you are, these children, these adults have a voice. They are intelligent. They know what they want. And the question then is, can they use that voice and can they get what they want? Next one. This is all about clinical assessment, and this was what you should be looking at. We are looking at other things apart from just what are looked at on research studies. Next slide, because we can be on there forever. Okay, we still measure muscle power for a lot of our children. We think it's an important way to understand the difficulties, that if you don't know what power somebody's got, you don't know why problems are occurring in function. And we still measure power. I know we are very unusual, but we still think it's quite important, except in the weakest children. And then we do a SCANT scale where we will look at things like can lift legs, can't lift legs. But generally, we still measure muscle power, which is unusual. Next slide. We don't use a lot of myometry. It is used in some tests. This is a myometer. We can use it for grip strength, but again, we do find in SMA that a lot of the children, because they have these wibbly wobbly bendy fingers, may not be able to do it. But some of the assessments use the French system, the Mayo tools, and that is being used for both fatigue and grip strength. And you may find that you are assessed on Mayo tools in clinic or in research assessments. Let's skip the next couple of slides. Joint range. Let's go to, let's keep going. Let's go to, not all contractures are the same. We know about contractures. We talk about contractures forever. Okay, let's hang on there a minute and see if there's any questions, Marnie.
We do have a few. One of them is, how often should these assessments be done?
If you look at standards of care, it will say every 6 months. If you are on a research trial, it will totally depend on the protocol of that trial. If the protocol says you will be assessed every 6 weeks, you will be assessed every 6 weeks, and that's what you sign up to. If it says you will be assessed every week, you will be assessed every week, and that is what you sign up to. Generally, it's every 6 months. With the MAA, the Managed Access Agreement for nusinersen, it was prior to first injection. It was following 4th. So between 4th and 5th, it was before the 7th, and then every 6 months from there. So that is where it goes with the Managed Access Agreement for nusinersen. At the moment, with Risdiplam, we have no regular assessment in the UK on the Managed Access Programme, but it should be every 6 months with clinic appointments. There is no point in people who are getting the Risdiplam on the compassionate use program not being assessed, because NICE are going to want to know what's going on. And this whole idea of people getting very, very iffy about NICE, saying, well, 5 years and then we'll reassess. And, you know, people are getting worried that NICE will withdraw treatments. Let's get real. If you're having an injection into your spine and it's not working, you would want NICE to withdraw it. Certainly if there's something better on the market or something different that is working more effectively. So while everybody's getting paranoid about the idea that NICE are going to say, we will pull the plug if it's not working, you know, quite right. Why would you be using something that's not working? On the other hand, nobody's going to withdraw a drug if we thought there was deterioration, if you stopped it, or if there wasn't something else coming up behind. And I think one of the big positives is there are things coming up behind. And in 5 years, we don't know where we're going to be, because certainly 5 years ago, we didn't know we'd be here now. And thanks to Treat SMA, obviously, we've been fighting for a lot more than we were ever going to get. But in 5 years' time, we will have a totally different cohort. We will have totally different numbers. We may have antenatal screening. We may have postnatal screening. We don't know. Every new SMA born may well go on to a pre-symptomatic drug, and we may see very, very few severe SMAs coming through in 20 years' time. We just don't know where this is all going. Only positive, though.
Okay. This is from an adult, and I can actually give you an example because I went through a similar concern. Is when doing these assessments, what should you do if you think something is going to cause you some pain after the assessment? So, for example, when they were checking my hips, I was really worried that it would set off my sciatica. So
then you tell them you don't want it doing. You are big people. You have every right to say, please do not assess that. When I have an ambulant 3 come into clinic, if I know they struggle, I will say to them, do you want to get on the floor? And if they say no, they have every right to refuse. I am not going to tell a teenager that they have to get on the floor just to embarrass them or make life difficult or something painful. If every child that comes into our department, the first question we ask them, Have you got any pain? Is there anything we need to be careful when we move or touch? And that is what should be happening with adults as well. The first thing you need to do is say to them, please be careful with my hips, because when you've moved them around, I get a lot of pain. You are big people. You need to talk. It is no good saying, oh God, I don't want that because it's going to make me hurt, and not tell the operator, not tell the physio, not tell the doctor. You need to do it. And it doesn't mean you will fail that test. It basically means that there are certain parts that can't be tested, and therefore your score is adjusted accordingly. So if there is a hip test that you do not like and it will cause you pain, you need to say that, because you need to be able to think that you will not get pain or problems from any assessment that is done to you.
Yeah. Okay, great. Another question, which I think you slightly did cover, but I'll ask it, is should they be measuring both sides? So should they be measuring both arms?
Yes. The upper limb scale, again, will measure both sides. Some drug companies, some natural history studies will only take the results of one, but if you don't measure both, you are losing information. And any sensible assessment center, even if the drug protocol does not ask for it, you cannot get too much information, but you can certainly get too little. And the way the pull is set out, it does measure both sides. So even if the information is not passed on to the drug company, that information is there for future analysis should it be needed.
Okay. Someone else is asking that, do you have to get out of your chair to have assessments done?
Not if you don't want to. I will always say to a teenager, do you want to come out of your wheelchair? But this is why they're developing the CHOP Attend. It is for non-ambulant people who do not want to leave their wheelchair, but they will ask you to use your tilt in space facility. They will ask you to put your legs up on a bed. So again, if you have pain or contractures and you don't want to do it, you must say. There is the EK scale, there are respiratory measures, there are upper limb measures, there are fine motor tests that they can do without putting you through any pain, discomfort, or embarrassment. And you have to speak up for yourself as an adult as to what you are prepared to accept. You need to be careful when you sign up to a trial, because some of the assessments, they will say you need to do it. So you need to be aware of what you will be expected to do if you're signing up to a trial. But when you're just on a managed access agreement, or if you are going on to Risdiplam on the compassionate use, then you have every justification in saying, can I please not do that test?
Okay. This one might be covered on, because you're about to speak about contractures, is should contractures be measured every single assessment?
That's very variable. If your contractures, if you're an adult and your contractures are pretty fixed, it's not going to make much difference. No drug, be it Risdiplam or nusinersen or Zolgensma, are suddenly going to cure your contractures and you're going to end up straight in 6 months' time. Afraid not, people. Contractures are there to stay. They are solid. Your muscles are tight, your joints are tight, your bones are fixed in a position, you're not going anywhere. For children, absolutely. And I do not agree, and that's me and my team, because me means my team, unfortunately, have to put up with my pain in the butt way of working. We measure joint range accurately with a goniometer, one of these things that you can measure properly. We measure hips, knees, ankles, we measure elbows, forearms, long finger flexors, and we'll measure absolutely anything else if we think it's tight. The forms say mild, moderate, severe. We don't agree with that. We agree with numbers, because if we want to do serial casting, if we want to splint, if we want to put kids in CAFOs, which I know not everybody does, then we need to be a bit more accurate. Also, one of the big things about contractures, actually SMA contractures in the smaller child, not so much the hips, but the knees, the feet, the elbows are manageable. And the muscles, when the children are little, are not fibrotic, they're not tight, and they can be stretched, but they need to be done properly and they need to be done regularly with the cooperation of the child. And there's lots of different reasons that things can get tight, and there's lots of different components to tightness. It's not just about muscles. The tendons, the ligaments, the nerves will all be shorter. So stretching is not just about stretching muscle, and it's not just about how it interferes with function. It's also how comfortable it makes things. It's about the position that you can get into to start with. I mean, if you're very contracted, it's very hard to sit out on a bed or get onto the floor. And this has to be taken into account. You also have to think about not only contractures, but when you're losing function. If you're very tight, then you're not going anywhere. But a lot of adults are now saying that they're worried about their arms, they're getting tighter in their hands, they may be getting tighter in their wrists. Even necks can get tight, and people forget that there are a lot of joints in the spine and neck. If you've had spinal surgery, fine, it's not going anywhere, but your neck still can, and it can get tight. And your shoulder blades can get tight. People forget that too.
Okay. I've been told I'll have assessments every 6 months, but I've been offered no physio in between. So I don't know what exercises I can be doing to help improve. Should I work out something from home, or should I push to have physio more regularly?
Well, the physio in your neuromuscular centre is not your physio in the community. Physio in the community is very limited. It's not the physio's fault, it's funding's fault. Funding has been cut dramatically. COVID hasn't helped, but those cuts were already in place long before COVID. This is, I'm afraid, successive governments' ways of privatising the health service. Most people have now got private employers doing a lot of the community services, and they're profit-making organisations. Let's get real. Physio has been cut to the bone. It's not acceptable, but you know, I can't do anything about it personally. We can complain, we can shout, we can ask, we can contact CCGs, but if the money's not there, the money's not there. But what we can do is have decent programs and community physios educated as to what programs you need. Now, if you're having no physio at all, there are two things you can do. The first one is go to your physio at your neuromuscular service and say, can you do me some exercises, please? We need something until we come back to see you next time. And if your physio is totally unable to do that, then we are happy to do that for you, depending on a lot of information we need from you about your child.
Okay. Right, I think that is it for questions at the moment.
Okay, we're getting tight on time. Let's have a look where we're up to. Let's move on to the next one. I think we're nearly finished. 48 of 69, maybe not. Okay, one of the problems we have is that people have got to remember that laxity can be as difficult as contractures, and that lax joints are difficult because they're hard to stabilize, they take a lot more power to control, and they can really interfere with function, as many of you will know from bendy fingers, difficulty with things like Lego, pressing switches and all these things. So laxity is an issue, and we need to measure that too. Next one. Let's forget hamstrings, because nobody should be stretching their hamstrings, and if your physio doesn't like it, they can look at me. We need to assess spines. These are all SMA spines. They are really, really important, and a spinal deformity is as important as any functional scale. Okay. We need to look at all the factors affecting posture and spines, and these need to be factored into your assessment as well. We need to think about what your spine is doing. If you can't sit straight, it's pretty hard to do an assessment. If you can't sit independently because your spine's wibbly wobbly, it's going to affect how you sit to do your assessments. So we need to look at all the things affecting posture, and obviously surgery is a big one. So when we are assessing, we need to very much document whether somebody's had surgery or not had surgery, because you talk about contractures affecting your outcomes and your assessments, but obviously spinal surgery is going to have a big impact on what you can and can't do. So that's another thing we have to think about, is not only contractures, but whether you've got a fixed spine, because it may really impact on your ability to move sideways, your ability to roll, your ability to lean forwards in the wheelchair. So this is something else we need to document and we need to think about. We also need to think about how long you sit in your chair, how comfortable you are. If you're not comfortable, it's very hard to do an assessment. If you're wriggling all the time because you're not comfortable, if you're skew-if, it's much harder to maybe work both sides equally. If you're doing an upper limb scale and all your weight's shifted over one side, or you're one of these people, it's much harder to use this hand. It's much harder to use this hand than this hand. So there's many things we have to think about. So posture has to be factored in to these assessments. So it's not just about contractures. It's not just about power. And this is what I'm saying. There is so much more that we need to consider when we're looking at outcome measures. Next one is mobility. So we need to look at mobility, because obviously the more mobile you are, unfortunately, the more assessments you need to do, because we still do the upper limb, we still do the 6-minute walk test, we do the Hammersmith functional scale, you will do the Maya tools. So there's quite a lot of things you will need to do if you're mobile, and also obviously you can lose mobility. And so we need to work on looking at how mobility or lack of mobility or reduced mobility or different mobility again affects your outcome measures. What orthotics do you use? You may walk independently, but you may need certain orthotics in your shoes. Now, one of the big things we have with 6-minute walk test is, in theory, you shouldn't do it with any insoles or splints or anything like that, but then you can't take them out because your shoes don't fit. So we need to think about that as well. We have one young man who's ambulant who has to wear his splints, and we've always left him in his splints. But on a research trial, they wouldn't let him. He'd have to bring another pair of shoes. We've had people who've turned up for a 6-minute walk test in flip-flops. I mean, not the easiest thing to walk for 6 minutes in. It's quite difficult. Something as simple as thinking you need decent shoes to do the 6-minute walk test is actually, people don't think about that. Do we have a spare pair of trainers with us? No, we've got high heels. And that's the boys. So there's a big problem, and we have to think about this. Okay, we need to look at, next slide. We need to look about, you do the 6-minute walk test. You're getting fatigue. What is the problem? You're falling. What is the problem? What are we going to do about it? So it's not just about assessing for the sake of assessment, but also as clinicians, we want to look at those assessments and think, how can I help? What are the difficulties? What's going wrong? Where is that weakness? Why is that person walking so asymmetrically? Why are they sitting so asymmetrically? Is it contractures? Is it weakness? Is it habit? And it's all connected. There is nothing that's wasted when we're assessing. Next slide. These are all the things that we're looking at when we are watching the 6-minute walk test. We're looking at how fast do you stay consistent, which is very rare. They zoom off, they slow down, they speed up, they chat a bit, we're told they've got 1 minute left, and suddenly whoosh, off they go, trying to get as good a speed as possible in the last minute. So it's a little bit erratic. We try and say go as fast as you can for the whole length, but walk, not run. Some people can't. Some people start getting more wobbly over the 6 minutes. Some occasionally will fall, and that's not a nice thing. We always take a wheelchair, even if the people don't use wheelchairs, for 2 reasons. Firstly, it's 6 minutes at least from our physio department to the 6-minute walk test. So they've already walked 6 minutes by the time they've got there, and they would have to rest, so we put them in a wheelchair. And the other thing is that if they do fall, then sometimes they want a wheelchair to get back, and that's not unreasonable. Next one. We have to think about all these things when we're looking at gait, even if we're looking at gait in calipers, even if we're putting them into CAFOs, we need to look at all these things affect the way somebody walks. So will affect outcome measures, will affect these assessments, all of them. Next slide. Okay, and then we need to look at loss of ambulation, but to be honest, we are hoping with these drugs that people won't lose ambulation, but it's not happening. We've already had one young lady who has lost ambulation, and we have worked like mad to try and keep her on her feet, and so far it's working. She is managing to do more steps than she was, but it's really difficult for her. So not everybody is going to find that by taking risdiplam or nusinersen you're going to stay on your feet, and then we have to think about that too. Okay, assessment of the older non-ambulant child. When you're on a trial, you don't get a choice. If you're going to go on to these drugs, they want that information. But when it comes to clinical assessment, then we will stop when somebody says stop. So that if you're going on to drugs, you have to think, I am going to have to agree to these assessments. That's the big problem. But if it's just a clinical assessment and somebody comes in and says, don't want that, teenager says to me, as a teenager did last week, and she is 18, so she has every right to say she did not want to get out of the chair and do all the assessments that mum wanted her to do. And at 18, she knew she could tell mum, I'm not doing it, and there's now what you can do about it, but she didn't do it quite like that, I admit. Okay, let's go on one. The important messages. Physio and assessments are boring, even for adults. Children are not small adults, they grow, and that's really important. So we have to take growth into account on top of absolutely everything else that we have to take into account. They can have different other conditions. There's nothing to say that you only have SMA. You might have asthma, you may have epilepsy, you may have 101 other things going on. By just having SMA doesn't mean you can't be diabetic or any other thing. So that we have to consider that as well. So despite what the assessment says and what the assessment reveals, is what we assess is really only half the story, because the most important thing about the assessment is what we do with the information, what we tell you, what we use it for to help you, what we do to try and prevent things getting worse. Next slide. Sorry, Marnie, this is a really big one for me. Children are not lazy. Children with SMA fatigue. If they don't want to do it, it's because they can't. It's not lack of motivation, it's lack of enthusiasm. They've tried it before and it didn't work. Why should I do it now? There are many, many things that will stop a child doing something, and they're not lazy. Lazy is a teenage phenomenon and gets better in girls and rarely in boys. But there is no, lazy is my 4-letter word, and no one, particularly grandparents, are allowed to use the word lazy when I'm around. Next one. Everyone can have a bad day. We need to look at poor nutrition, and that's for adults as well as children. Recent infections, illnesses and trauma. We've got to consider traveling to the centre. Sometimes parents, children and spouses are helpful, and sometimes they're not. It really never helps when mommy's going, don't worry, darling, the nasty lady will be finished soon, which is one of our mums consistently does, which is why we never get a decent assessment out of this child. Not madly helpful, mum. Knowing when to stop is really important, and knowing when to have a rest. And that's another thing as adults you should be able to say. If you are tired, if you are needing a rest, say, can I have a rest, please? Can I have a drink, please? Can I just have 5 minutes to get my breath back, please? There is no harm in saying that. It is not allowed. Okay, now, really, really importantly, and this is one of the big things, next slide. We need to impress on people this idea of these are numbers, not functions. The difference of 2 may be significant if it means that you can no longer get up from the floor, but it may not be significant if you can no longer hop. Do you really need, as a 20-year-old, to be able to hop? Is it the most important thing in your life? You can't do it anymore? Big deal, as long as you can do the things that are important to you. So this is really, really important. These 2 points are not the end of the world. They seriously are not. And to say the 2 points of being able to hop and the 2 points of being able to get up on the floor, or the 2 points of being able to do something else, are not the same 2 points. Okay, let's skip a couple of slides. That's where are we going to? Okay, let's go to next one. No 2 children, adults and families are the same. So irrespective of whether you gain or lose 2 does not mean that you're going to do it the next time. It doesn't mean that things are all bad. It doesn't mean that the friend that you've just emailed to say, I lost 2, what did you do, is going to be the same. Everybody's different. Everybody is affected differently. We can't compare one person with another. You can't compare yourself or your child with someone else. You are all individuals. We need to treat you all as individuals, not just as numbers, not just as functional scores, not just as outcome measures. You are individuals with individual needs, individual things important to you. Don't ever forget that, and don't let the physios or anybody else forget that either. Okay, so the main things with assessing adults: weakness and deformity, spinal surgery, reluctance to get out of the wheelchair. That is completely up to you. I accept that always. For my older teenagers, you may not want to perform all the tests if you're ambulant. Finding outcome measures that you feel that you can do. And the big problem we have with adults, as everybody knows, is there are very, very few studies ever been done on adults. And this is very depressing, that there is so little information about adults and how they deteriorate out there, because we know they deteriorate, particularly in arm function. There are a number of people I have spoken to recently who've told me, and these are 2 people I have spoken to recently, are borderline 2-3s who are telling me they have to lift one arm with the other. So people think that type 3s are fine if they lose ambulation. They are fine. They will be strong forever. They will not. They will not. And we need to be aware of this. But there is a caveat to that. Lack of exercise is a big issue, folks. You're not exercising enough. Sorry. Okay, let's have a look at the adult scales. The EK, to me, is one of the best ones. The MFM is used in some trials, but it's a nice round scale. It has upper limb, it has lower limb, but you need a lot of training to be able to do it. The upper limb is fine. The tug for ambulant people rather than getting on the floor. Activity monitors are definitely where it's at. Fatigue needs to be considered in adults. We consider it in children, but I think we forget about it in adults. You need to say if you're getting tired when you're doing testing, and quality of life or well-being. Next slide. As I say, my feeling is that well-being is an issue, burden of care. We talk about burden of care for parents, but you know, there is a burden of care for adults as well, with your carers, with your families, with your spouses, with your partners, whoever. So it's not just about parents. It could be children. We know that there are children of people with SMA. What is the burden of care for a child who has a parent with SMA? We forget about those. We seriously forget about asking the children who have parents with SMA about what they see as the burden of care, or what it's like for them, what it's like for siblings. And we always forget siblings. Next one, a website. If you really want to look up a lot of information that you never needed and you will never want to know, that is where you can go to. And the last slide. Nobody starts out being an expert. We are all beginners. And we're all in this together, and we all need to be open and honest. If we can't do something, if we want to do something, if we want to try something, get out there and talk. Use your voice. You've got one. Nobody should make you do something you don't want to do. Nobody should put you through as an adult. Now, there are a lot of set tests that we do with the children. We should be explaining them. We should let you know what we're up to. We should give you options and choices. This is not about forcing you into anything. Assessment is really important, but it's only part of the bigger picture. Okay, last questions, Marnie. Sorry, we have overrun.
A lot of the questions that I've asked you've kind of covered through the last bit.
Yeah.
One that we'll do and we'll finish on, because I think it's quite important, is there a set time to do the assessments in? When my daughter was having her assessment done, I felt like she was being rushed through it and that she would have actually achieved more things if she had been given time.
Yes, it's really, really, really important that you are given as much time as you need. If you feel that they are rushed, particularly with SMA and particularly with the type 1s and the weaker type 2s, movement is slow. We do not move at speed for these children, and we need to give them time. I have had a child, she's not a child anymore, she's a teenager. The most determined young lady could take 5 minutes to get from lying to sitting. And she did it, and she insisted on doing it. And it took her a long time, and she did it every time she came to clinic. But she did it, but she needed time to do it. She had to move each bit of body one bit at a time, and she achieved it. And yes, it is only fair, because a child will tell you when they can no longer try any harder and do something, as an adult can. If they say, no, I can't do that, fine, you go on to the next thing. But there's no point in rushing them and not giving them the opportunity to try. And while in research trials, you are only allowed 2 attempts, in clinic, you can try as many times as you like. If you think go 3 or 4 or 5, you will achieve what you want to achieve. If you've had enough, you've had enough. We say so, that's fine, move on. But if you're still trying, do not let your child be rushed. Or if you think they've been rushed, say something to the doctor.
Okay.
And the same goes for adults. Do not let them rush you through these assessments.
Yeah. Okay. Yeah, as I say, I think you answered quite a lot of the remaining questions.
Okay, no problem. Marnie, you and I are having a break. Yeah. Everybody have a lovely, lovely Christmas. We will see you on January the 10th.
Have a lovely Christmas, everyone.
And you. Take care. Bye.